Again, with time you will develop your preferences. So for example, if I am doing surgery, I will do everything with number 15 blade. But if you are not comfortable for your clavicular incision, which I will be discussing later, you can use number. And number 15C is a narrow kind of 15 blade, and it is for basically when we are using loops and all. So it gives precise incision, less trauma to the tissue. So when we are talking about incision, always remember one thing: if you are raising a flap and you are raising a full thickness flap, your blade should hit the bone. So if you don't do that, your life becomes tough. Why? Because I am raising a full thickness flap. For partial thickness, actually I have to use a blade. But now I will be using a periosteal element. So when I do that, I will definitely tear the flap, or the procedure will become very tough. So whenever you are finding it difficult to raise the flap, most often, 99% cases, the problem will be that your blade has not hit the bone. So basically, periosteum is already attached, even connective tissue is attached, and you are not able to raise the flap. Okay, so whenever we are aiming for a full thickness flap, my blade should hit the bone. Same goes for your clavicular incision, which I will be discussing, that it should hit the bone. Then coming to periosteal elevators, so many are there, okay. And the motion used is basically known as a prying motion. Slowly I will just try to lift the flap from the periosteal attachment. Okay. Simple, slowly, and once you have hit the bone actually, so whenever you are trying to raise the flap, you will be lifting the periosteum. Where is the? The baggage and where is it? Okay. So this motion is known as prying motion. So slowly we should reflect the flap so that we are not tearing. Because as I told you, most often we are raising flap to augment the bone. So if I tear the flap, the purpose will be defeated because I want to cover that graft and I am not able to cover that graft. So coming to incisions, so we have two main incisions, that is horizontal incision and a vertical incision. So horizontal incisions most commonly used for flap surgery are crustal, clavicular or circular. Gingival crevice what we call, or gingival sulcus we call, so that's why that becomes a circular or clavicular incision. And last is your periosteal releasing incision. So if I have to basically displace the flap, so I have to see whether it is mobile or not. So I can enhance that by giving a periosteal releasing incision. So all the incisions given in this direction becomes horizontal and this direction becomes vertical. So vertical releasing incisions. So coming to the first one, the crustal incision. So you saw it yesterday also. So this is the mid-crustal incision, very commonly followed, and most often we follow this whenever we are planning that okay, I am not augmenting the bone, or I have good amount of keratinized tissue on the buccal side. Now we can shift it to palatal or lingual side if I am planning to augment in aesthetic areas, or maybe my keratinized tissue is less. So in stage 2 what we'll do, anyhow 4 mm implant is there, I will push it on the buccal side. So that will enhance the keratinized tissue on the buccal surface once I am placing the gingival bone. So that slowly you will understand why we play with this incision line. So why mid-crustal incision or crustal incision? Because there is less bleeding, because it is a keratinized tissue. Edema will be less when bleeding is less and easier to manage. Next comes your clavicular or circular incision. So you can see it is basically in the crevice, gingival sulcus. So whenever you will be giving this incision only in cases of the side which is in between your dentulous area. If you are planning for a edentulous area, it will be just a crustal incision or a vertical releasing incision. So that's why you need this only when you are planning a dentulous area, between the dentulous area. So you need to give this clavicular incision. So this is the periosteal releasing incision. So when we need to advance this flap, okay, we are finding a hindrance even after going beyond the mucogingival junction. So we will release the closure. The reason is at that time you will get the closure, okay, because of your suture strength. With time, suture loses strength. So if it's not passive closure, it will go back, and definitely it can expose your membrane or graft material. Coming to vertical releasing incisions, so based on these incisions, we'll be talking about the flap designs. So it can be a single vertical releasing incision or a double vertical releasing incision. So something which you need to understand is, can you see how incisions are being given? They are divergent. Why? Why not like this? Blood supply, very good. So always remember that your base should be broader. Okay. Because once we reflect the flap, whatever blood supply is coming from beneath. So इससे पहले हम जब इंसिजन दे रहे थे, जो हम पहला फ्लैप डिस्कस करेंगे, उसमें हम वर्टिकल इंसिजन्स नहीं देते थे, लैटरल एरिया आती है. The moment you give the blood incision vertically, the blood supply from that region is gone. So that's why your base should be broader. Okay. Another thing you have to keep in mind that you can't split the papilla. So yesterday also, when the demo was given, the mentor told along the line angle. So always remember that the vertical releasing incision will go along the line angle. So this is the right way of giving the vertical releasing incision. You can't split the papilla. You can't give incision on the eminence of root. Why? Closure will be tough. Eminence पे सबसे ज़्यादा एक पहाड़ पे चढ़ना है ना, तो एक तो closure will be tough, plus blood supply also will be tough. So we always give in interradicular area. So always remember this. So these are the things which you need to avoid. Avoid splitting the papilla. Okay. You can't have a narrow flap like this. So if you see over here, it's a divergent incision. It is sparing the papilla. It is on line angles, but still you can't give this because the flap is very narrow. Okay, got my point? So though it is following all the rules, the flap will become very narrow. So again, we need to avoid this unless we have a good space between the two teeth. Then definitely incision on the radicular surface has to be avoided. As I told you, it is like a hill. So even closure will be tough, and the blood supply reaching over here during the healing will be tough. And base can't be bigger than your top. Okay. So it has to be a divergent vertical releasing incision. Clear? So when we are giving vertical releasing incision, so few areas need to be avoided also. Unless it's really required, we avoid giving vertical releasing incisions like in palate. Why? I can damage the greater palatine artery. Lingually, again, because your lingual nerve comes. Then canine eminence, definitely by mistake also you can't give it. You see, you feel the tongue, सबसे ज़्यादा prominent area है वो canine है. तो अगर इस पे आपने vertical releasing incision दे दिया तो even gingiva won't forgive you. So I tell you, gingiva is very forgiving, but in this region it won't forgive you. Okay. And definitely in mental foramen area. So whenever we are giving incision, even if we need to give incision in that area, I should be knowing the location of mental foramen. So I can go up to mucosa, but can't give blindly like this. Because if you give like that, there are chances that you can sieve your thing out. So few basic principles always use. Okay, so sometimes when we are doing surgery, we'll be using some 3-4 blades. Why? The moment it touches the bone, the blade becomes blunt. So it's a long surgery, a long area, definitely we might need to change the blade. Even your periosteal elevator should be sharp. So all this so that we avoid damaging the tissue. Avoid any anatomical structures, as I told you before. So incision should avoid such anatomical structures. So once you reflect the flap, the main aim is visibility. So I should be able to see the area. तो जब हम flapless की बात करेंगे या there are few designs where I will be telling you to conserve the tissue, तो वो minimal invasive आ जाता है. पर minimal invasive का मतलब ये नहीं है that I am not able to see the area. I need to see the area. I need to augment. Then I will go for conventional flap. Okay. And definitely clean margins. Your suturing will be easier. Approximation will be easier, and healing will be faster. So always remember this thing, your base should be broader, okay, so that you have enough of blood supply, and then see, if this defect is there, I can't have exposure like this. Though I can see the area, but it's preferable to have something like this, so that if I need to augment the area, I have areas to place the membrane. If I need to place a DAC or something, I can easily place them. I shouldn't be struggling. The most important thing about the vertical releasing incision is there that once you give it, you can't go beyond it. आप clavicular में कर सकते हो. I'm giving an incision. If I need to reflect it, मैं आगे चला जाऊँ. मैंने जैसे vertical releasing incision दे दिया, तो that is the end. अगर उसके बाद मेरे को थोड़ा सा और exposure चाहिए, तो मैं दोबारा से vertical releasing incision नहीं देता. So that's why we should be careful when we are giving vertical releasing incision. So that's why we need to have an extra teeth involved. If I have to plan a vertical releasing incision, it's always preferable teeth. तो मेरे को canine का चाहिए, तो मैं lateral का papilla भी involve करूँ. So that it becomes easier for me. Later on, I can't change that vertical releasing. So now coming to various types of flaps. Okay. So first, based on exposure of bone. So it can be full thickness or a partial thickness flap. So most commonly when we are placing implants, that is stage 1 surgery, we go for full thickness flaps. तो partial thickness flaps हैं, वो usually जब हम stage 2 surgery करते हैं, तब हम plan करते हैं so that we can augment the tissue, soft tissue around the implant. Then coming on to flap placed after the surgery. So one is non-displaced, other one is displaced. So as the name suggests, I am displacing the flap. तो non-displaced क्या है? मैंने ये reflect किया और वापस ऐसे सुचेत करो. Displaced क्या है? मैंने यहाँ पे grafting की. I need to displace it coronally. Okay. So for that, we need to give vertical releasing incisions. कई बार हमें minimal pull चाहिए होता है, तो what we can do is just go beyond the mucogingival junction. So that also gives you some amount of mobility or agility of flap. There is no need for vertical releasing. So avoid vertical releasing incisions as much as possible. Then definitely we can preserve the papilla. So I told you a crustal incision, clavicular incision. The moment you join both the teeth, you are splitting the papilla, future papilla. So we can preserve those papillas by giving mesial or distal or combination of them. I will be showing you the pictures. But it is not possible in all the sites. The reason being, I need a broader area. I need to preserve at least 2 mm of tissue over there. Then only it will survive. तो वो necrose ही हो जाएगा. तो जो मैं preserve करने की कोशिश कर रहा हूँ, it won't be preserved. So now coming to choice of flap, how to choose it. So if I understand this, I am done. आपका flaps and they are very easy. You might be assisting and seeing those flaps in day-to-day surgery. So first is amount of bone available. So if I need to augment the bone around the implant or before the implant. So GBR can be done before the implant. So if I am not achieving primary stability, I can't place the implant. So I need to augment, so I have to reflect the flap. Okay. So if I need to augment bone before or during implant surgery, I need to reflect the flap. Thickness of soft tissue. So thickness means, so if we are talking about partial thickness, then definitely there should be some amount of thickness over there. 1 mm का thick चल जाएगा, I can't give partial thickness, necrose ही हो जाएगा, ठीक है? So then I need a 2 or more than that thickness of keratinized tissue to give a partial thickness. Width of keratinized tissue, again, as I told you, I showed you an example that we can go for palatal or lingual incision. If we want to shift some amount of tissue on the buccal side. Or if we are talking about flapless surgery, where we give punch. So if I am giving a punch of 4 mm, I am removing 4 mm of keratinized tissue. And if there is no enough keratinized tissue on buccal side, then I have to take a FGG and augment the area. So actually not all cases are indicated for flapless surgery. I need to reflect the flaps. Anatomical structures, definitely as I told you, which areas to be avoided. Aesthetic zone, again, I need to be more conservative if possible. Aim for less of vertical releasing incisions or a palatal or lingual incision. The number and location of implant, again, decides what kind of flap I might be doing. And definitely, as I told you, there are various modifications in surgical technique depending upon whether I am going for stage 1 or stage 2. So stage 2 ऐसा भी है कि आप एक छोटा सा इंसिजन दोगे, रिफ्लेक्ट करोगे, फॉर्मर लगाओगे, ओके. और ऐसा भी होता है कि पूरा रिफ्लेक्ट करके हमें डिस्प्लेस भी करना पड़ता है. ठीक है, so it depends upon what kind of procedure I am doing and at what level I am doing. So what is the aim of that procedure? So coming to based on bone exposure. So your flap will look something like this. The full thickness, if you can see, bone is exposed. Your periosteum along with connective tissue and epithelium is raised. When we are talking about partial thickness, some amount of connective tissue is on the bone, epithelium and connective tissue is part. So this can be elevated with periosteal elevator. This requires blade. So that's why if you are given a partial thickness incision, you will always struggle reflecting the flap with your periosteal elevator. So revisit your incision line if you are struggling to reflect the flap. So this is how clinically it will look. So can you see the bone over there and some amount of connective tissue over here? Okay. So this is the case where full thickness flap was raised. So there is a defect over here. We augmented the area with bone graft. Membrane, collagen membrane has been placed, tacked with cover screw, healing cap and sutured well. So in such cases, definitely we need to reflect the full thickness flap whenever I am working. So when we will be talking about treatment of peri-implantitis, we will be talking about regenerative therapy around the implant, we need to reflect the full thickness flap. So partial thickness flap, so usually when your bone is thin or when I need to augment the area with soft tissue, usually it is done during this. So partial thickness flap is most commonly done during your stage 2 surgeries. Okay. So this is the case. So if you can see buccal, your keratinized tissue is less. So what has been done? Incision is given, partial thickness flap is reflected and sutured beneath. So now this epithelium and connective tissue forms the part of keratinized tissue. जो ऊपर वाला connective tissue है वो automatically heal होगा. So this is how we, during the stage 2, we can raise a partial thickness flap and enhance the amount of keratinized tissue around the implant. ये बक्कल ठीक है। अच्छा, क्रिस्टल इंसिजन की बात करें, हाँ वो थोड़ा सा है ना, देखिए लिंगुअल है। अब ये देखो ना मैम, यहाँ पे बोन भी नजर आ रही है, कनेक्टिव टिश्यू है ना, डिस्प्लेस फ्लैप है ये और पार्शियल थिकनेस दोनों। नेक्स्ट आएगा एग्जैक्टली, लिखा है पार्शियल थिकनेस। तो डिस्प्लेस को हम रीपोजिशन भी कहते हैं, बिकॉज आई एम नॉट प्लेसिंग इट एट द सेम लेवल और सेम प्लेस, आई हैव रीपोजिशनड इट, डिस्प्लेस्ड इट। वो हम कोरोनल भी कर सकते हैं, अपाइकल भी कर सकते हैं, ठीक है। So now coming to this thing, non-displaced, where we are placing the flap back to the original position. Displaced or repositioned, that can be coronally advanced and apically advanced. Rarely laterally advanced. Laterally usually हम जब root coverage कर रहे होते हैं तब करते हैं. But in these cases, around the implant, usually it is coronal or apical. तो apical का example जो पहले था, जो partial thickness था, उसमें आपने apically displace भी किया flap को. Okay. Now coming to preservation of papilla. So if we modify our crustal incision like this, I am preserving the mesial papilla. I can preserve the distal papilla. I can preserve both mesial and distal papilla. Okay. क्योंकि जो मेरा अगर 4 mm का इम्प्लांट है तो मैंने रिफ्लेक्शन जो है अराउंड 5 mm का किया, तो वो पैपिला को स्पेयर कर सकते हैं. But this can be done only in cases where your bone width is good. It is like a football ground. 8 mm bone है, there is no way straight है, there is no way you can go wrong. इतना रिफ्लेक्ट किया और 4.5 mm का इम्प्लांट है. वो aesthetic areas में, and definitely I need a wider mesodistal distance. ये तो मेरा वो, मैं आपको next slide करेगा. So this area, अगर वहाँ पे चलिएगा, this area should be 1.5 to 2 mm. ये डबल है. So we can give incision. Can you see? ये implant place हो गया और ये survive कर जाएगा. इससे कम होगा तो it will necrose. So that's what we have to see. Apart from aesthetic area, we have to see कि मेरा mesodistal distance अगर 6 mm है, then it is not possible. So अगर मेरा mesodistal distance जो है 8 mm है and I am placing a 4.5 mm implant, it can be done easily. So now, based on incision, whether we are giving vertical releasing incision or not, it becomes an envelope flap. Envelope देखा आपने? सिर्फ ऐसे ओपन होगा. Or you can have a triangular flap. So triangular में हम एक single vertical releasing incision देंगे और trapezoidal flap में 2 vertical releasing incisions देंगे. So this is how your envelope flap will look like. Okay. So you will give a crustal incision and clavicular incisions and just reflect the flap. Okay. So it is like a envelope which is coming up. So we can, as I have told you before, paramedian. Paramedian means I am not giving in the middle. I can place it palatally or equally. That can be done. So this is the case showing reflection of a envelope flap. Over here, the palatal has not been raised. So definitely when bone is less or we are aiming for a palatal placement of implant, we need to reflect palatally also. If we have sufficient amount of bone, we are placing implant in the region, normal position of the implant, then there is no reflection of flap required palatally. So this is how it looks like, clavicular and mid-crustal incision and reflection of full thickness flap. This is how it is done. These are few departmental cases. Over here they have used Densa, so later on we will be talking about all these things. Then coming to triangular flap, as I told you, apart from your crustal and clavicular incisions, you will be giving a vertical releasing incision. case where one vertical releasing incision has been given. So now over here, after placement of implant, you can see few threads are exposed. So we need to augment the bone. So I can't go for flapless surgery over here. I need to place the bone and place a membrane and then suture it. So over here, titanium mesh was used. So advantages, definitely no vertical releasing incision, so good blood supply, satisfactory visualization, good reapproximation, and can be modified. बोला clavicular जब आपने incision दिया हुआ है, you can modify it. No vertical releasing incision ना तो मैं आगे भी जा सकता हूँ, पीछे भी जा सकता हूँ, तो extend कर सकता हूँ, vertical releasing incision भी दे सकता हूँ. Disadvantage क्या होता है? Limited access. Advance करना है इसे, तो then it becomes tough. I need to go for vertical releasing incision. Then coming to trapezoidal flap. But what we have to remember is base should be broader. Now, आपका जो envelope flap है पूरा दोनों लैटरली भी आ रहा है और अपाइकली भी आ रही है, ब्लड सप्लाई बेस से भी आ रही है. सिंगल इंसिजन में दो साइड से आ रही है, इसमें सिर्फ एक साइड से आएगी आपकी ब्लड सप्लाई. सो बेस शुड बी ब्रॉड. सो गुड विजिबिलिटी डेफिनेटली यूज फॉर योर extensive GBR procedures, but then again it can't be modified as I told you. The moment I give vertical releasing incisions, it can't be modified. वो मेरा excess flap उतना ही रहेगा. And plus scarring is there, healing becomes a problem sometimes. So this is another departmental case. So after extraction, buccal defect was there. So implant placement was done, grafting was there, and your collagen membrane was stabilized using that. Okay. So it required extensive coronary advancement, so that's why two vertical releasing. So these incisions should go beyond mucogingival junction. आपका keratinoid tissue mobile नहीं है, so you have to go beyond mucogingival junction. Once you are in mucosa, then only it becomes mobile. So few modifications can be in aesthetic area. Okay, we can go little bit palatal or lingual so that we can augment the keratinoid tissue in stage 2. On the later stages, buccally we can augment the area. This is an example of your patella sparing. So implant is of smaller diameter, I have excess amount of space, measured speak, so then we can spare the patella. Even augmentation was achieved in this. Certain conditions like this can be seen. So where you have your dentulous area till canines or premolar, you have complete distal extension. So depending upon number of implants, it can be just a crustal and clavicular incision. If I am placing two implants, actually I can just extend it distally. There is no need for releasing incisions. But if we are planning an extensive surgery or maybe more number of implants, then I might need to give releasing incision. And you should be careful about your lingual releasing incision. So if it can be avoided, you should avoid it. So we are talking about flap, it shouldn't be extensive, but then certain conditions require this. Why? This is a all-on-4 case. So maxilla, so what we aim at, that all implants should be at same level. तो resorption pattern ऐसा नहीं होता कि ऐसे flat ridge मिलेगी आपको, वो ऐसा होगा, zigzag. But while placing the implant, we need to flatten the ridge. So you need to extensively remove this. Now, of course, it can be reduced using guided surgery, but it is required to raise a flap at least to flatten the ridge. Again, in mandibular, as I told you, few people expose the mental foramen. So that now they know that okay, my implant has to go ahead of this. I am safe. There is no point they will cause any injury to this mental foramen. So these are the things which we have already discussed. So basically, flap reflection should be such that it is achromatic, avoid giving vertical releasing incisions, follow the rules so that healing is proper. Now, whenever we are augmenting, okay, so it is always preferable that I give a palatal or lingual incision. The reason being my suture line will come palatally. So my implant fixture or my graft is away from my incision line. So these small things can be done when we are planning for such procedure. Then minimal tension should be there when we are closing the flap. So apart from giving vertical releasing incision, okay. So whenever possible, we can go for flapless surgery. The issue with it is the clinical expertise. We should be oriented with the angulation if we are not going for guided surgery. Now, if you are going for guided surgery, then like this, easy. So, advantages and disadvantages, you can take a picture. So, most of the things we have discussed. So, excess is less in your flapless surgery. It requires some amount of expertise. Okay, and definitely if you are planning for a guided surgery, it becomes easy. And we'll go for flap surgery when we need to see the bone or we need to augment the bone. So this is a case of flapless approach. So you can see we have sufficient amount of correctness gingiva. That's why even in posterior you can go ahead with such procedure. So this is over-denture case done with guided surgery. So remembering that all on 4, how much extensive flap was raised over here after implant placement. So things can be changed to flapless. It becomes less extensive. Healing will be faster provided we don't need to access the bone. So if you see the ridge, it's almost flat at same level. So this is an over-denture case. So 2 implants at same level, parallel, done. Most often we won't find this. So then definitely even your guides come along with surgical stent. If you are planning all on 4, all on 6 days, so they come with surgical extent. That, okay, how much bone recontouring has to be done. After that your surgical, this implant stent will sit. Okay, so you have number of stents. So sometimes after implant placement, only soft tissue augmentation is required. So there are few case reports where they have done hard tissue augmentation also using this flap. Soft tissue augmentation we also commonly do using this, that is known as Mr. technique. So you can give just a vertical releasing incision and push the connective tissue. So now you have not raised the flap, it is not extensive, even your incision line is in vestibule. So even if Akshay Kumar smiles, we can't show his vestibule. Okay, he will be able to show the gingiva. So you can't see the incision line after healing. Okay. Kind of around it. Because over here we are just planning to push the connective tissue to augment the area. We are not advancing it. So to recapitulate, these are the various flap designs. There are advantages and disadvantages. So 2 slides are there. You can take photos. So we have covered all this so that you remember which one to use. Where. So flapless, flapless pairing, angular flap, triangular flap, trapezoidal, and vestibular incision. There are few case reports where they have grafted the area also using vestibular technique, but then how much, because without membrane actually augmentation, how much it occurs is questionable. Soft tissue procedure, definitely we regularly follow this protocol for root coverage procedures, so it can enhance the correctness tissue. So whenever we are talking about conventional implant surgery, reflection of flap is mandatory. At your level, definitely you have to reflect the flap, see the bone. It's a learning experience. Okay, you should be able to judge. And once you are through with it and it doesn't require augmentation, you can switch to flapless or guided itself. So, one video of flapless is there. Okay, so this is the guided stand. So initial pilot drill will be done so that we know, okay, from where we need to remove the punch. But see, so whenever we are teaching, we learn with every day. So I was searching for this video. Now there's something new even I learned from this. So what is that? So this is the tissue punch. So till now, what we have seen, punch and remove. Okay, here you won't do that. So round burr to remove the epithelium, and now the connective tissue we will push to the buccal side. So this is something new I learned from this. So there are n number of procedures. Slowly, when you keep on doing, you understand, okay, how to play with the tissues. So now, otherwise, in most of the cases, previous cases, I showed you whole punch was removed, and then later on they are taking out connective tissue and pushing it. Over here, you just remove the epithelium, that 4 mm is pushed on the buccal side, and you will place it. So many a times, if bone is sufficient, so just initial pilot drill. They prepare the guide, and after that you can go ahead with plan. So this is the flapless, and over here they have given temporary restoration also. So yesterday few were asking about screw retain. So this is the screw retain process. Okay, so you just screw it, and you can place a Teflon or cotton inside so that once you fill the filling material, your screw hole doesn't get blocked. You can put the contour. So what that the mentor was talking about, screw mentor. So in that you will have this excess hole in your cement retained also. Usually, so he was of opinion of using cement retain. But if you go through textbook, most of the prosthodontists will tell you screw retain. The reason what he forgot to tell you is that cement, you can't control that. So when you place a cement retain crown, the cement will flow into the peri-implant area. And it's very tough to retrieve it. Okay. So that later on leads to peri-implantitis. So actually when we'll be talking about reasons of peri-implantitis, one of the foremost reasons is cement inline. So still, in my clinic, I do that. So there are 2-3 techniques which, of course, I have learned from others. It's not my invention. So one is your excess hole. So whenever you place crown, most of the cement comes out of it. Another technique somebody told me was interesting. So what he used to do is take the model, crown and cement डाला, place the crown on that. तो excess cement पहले निकल जाएगा. Wipe the gingival area with cotton and then place. मतलब वो मैम होता है इतना. You will get working then, good amount of work. So this is another way of reducing the cement indulgence. So actually screw retain are preferred because of this problem of cement retain. But if you are going for cement retain, it's preferable to give that excess hole. In that way, he was correct, because if you are giving a cement retain like this, so for example, what we face with basal implants. So if patient comes with any problem, so either we have to send him back, this is what we usually do, or we have to remove all of the processes and then see what has to be. आ जाता है, पर फिर उसमें भी ये होता है कि जो एपाइकल एरिया से निकला है ना वो वहाँ पे रहेगा, उसकी क्वांटिटी कम हो जाती है। तो प्रेफरेबल ये है कि आपने जब कास्ट पे किया तो वहाँ पे निकल के आया, आप उसे वाइप कर सकते हैं, तो वो मिनिमल अमाउंट जाता है जब आप पेशेंट के मुंह में करते हैं। तो दिस इज हाउ यू कैन ट्राई, बट प्रेफर्ड वंस आर स्टिल screw retained until it's a aesthetic area and your excess wall is coming buckling. With composites and all nowadays, buckle also. उसमें बस ये प्रॉब्लम आती है after 6 to 8 months margins पे staining हो जाती है. Then either you need to do the cut again, or just take a fine bar, move it once, and it goes. That is during the implant placement. So I have, that's what. So conventional implantology is prosthetically driven. So when I, so जो हमने अभी टेम्पलेट भी देखा था, तो उसमें टूथ का टेम्पलेट था, उसके थ्रू ड्रिल किया. So that drill went to the palatal aspect. So definitely वो buccal आएगा ही. But this is now if I have ridge like this, how I control that? Even if I go very much palatal, still chances are that I have to give angulated abutment. So we try to control it by giving angulated or castable abutment. But if it is not possible, then we have to go for cemented. उसमें issue ये आता है कि अगर हम जो cementable बोल रहे थे, अगर वो करते हैं तो excess wall तो आना ही है, तो it's better to give them screw retainer. We should avoid it. But I think 20-25% of the cases it is not possible. So we have to use angulated abutment. Sometimes we get excess wall. In that when the बात करेंगे तो स्माइल लाइन और पेशेंट व्हाट ही और शी वांट्स. So for example, if a patient doesn't want too much of aesthetic, even a excess wall on cervical area of anterior doesn't matter. Few people can object to it. Depending upon that. Ma'am, it was not required, but in a way you got that amount of visibility because of that. So actually अगर हम सिर्फ crystal और clavicular लेते, that was sufficient enough. What he was planning was to place a bigger implant. वो थोड़ा सा area constraint था, तो premolar size का था. अगर वो molar area में हमें bigger implant place करना होता, then that incision was required. The reason being वहाँ पे हमें 100% augmentation करना पड़ता. Already some amount of buccal bone thinning was there, पर इससे बड़ा implant डलता, अगर 4.25 डलता तो फिर वो exposure आ ही जाता. So then you need to augment the area. So that's why that incision was required. Ideal dimension, so that thing also he missed. Basically, when we are planning an implant, okay, in a dentulous area surrounded by two teeth, so what we have to remember is that mesiodistal width should be 7 mm. Why 7 mm? I am planning for a 4x10 standard implant. So 1.5 mm from the mesial area and 1.5 mm from the distal area, it should be there. There are two reasons to it. One, definitely resorption of bone in the interdental area. Second, if it is not followed, later on your prosthetic components won't fit in. Because we need to take impression, so impression material flow करना चाहिए ना. अगर tooth और implant का जो हमारा component है वो बिल्कुल ऐसे हैं तो हमारा impression material नहीं flow करेगा. So that much amount of space is required, minimum. Buccolingually 1 mm of circumferential bone should be there, at least 1 mm. Recent studies say कि आपको long term चाहिए तो 2 mm, but at least 1 mm. So now that ridge width was around 4.6, थोड़ा सा हम 5 तक जाएंगे तो 5 हो जाएगी, and I place a 4.2 mm implant. अगर मैं lingually 1 mm छोड़ रहा हूँ, I have to leave that. The reason being lingual को हम touch नहीं करते, तो buccal exposure आता. Buccal exposure आता तो I need to open that. So that releasing incisions were for the benefit of audience so that they can see the surgery. Plus, he also wanted to see how much thinning of bone occurs. So थिन होगी थी और एक्सपोज नहीं हुआ था, देन इट्स गुड इनफ, नहीं तो शायद हमें ग्राफ्टिंग करनी पड़े। तो इमीडिएट अगेन, तो बेसिकली जब हम सीबीसीटी प्लेसमेंट या स्टेज 1 सर्जरी की बात करेंगे ना, देन विल टॉक अबाउट हाउ टू गो अबाउट इट। तो प्लानिंग स्टार्ट बिफोर एंड। तो हमने सीबीसीटी देखा, सीबीसीटी में अगर मेरे को लग रहा है मेरे पास, फर्स्ट वी टॉक अबाउट द डिलेड वन, मेरे को लग रहा है कि थिन बोन है पर अपाइकली वाइड है, आई कैन गो फॉर साइमल्टेनियस इम्प्लांट प्लेसमेंट। सो देयर आर टू थिंग्स, स्टेज एंड साइमल्टेनियस। स्टेज क्या है, मेरे पास बोन कम है, I will regenerate the bone first and then place the implant. So that takes 6 months. Okay, 4 to 6 months we have to wait. Simultaneous क्या है, मेरे को लग रहा है कि मेरे को प्राइमरी स्टेबिलिटी मिल जाएगी, प्राइमरी स्टेबिलिटी आ गई, then डिफेक्ट जो है उसे मेरे को ऑगमेंट करना। फॉर एग्जाम्पल स्टैंडर्ड रिज है, 7 mm थिकनेस है, 4 mm इम्प्लांट प्लेस करना है, तो इट्स इजी, यू कैन गो फॉर फ्लैपलेस आल्सो। कोई ज़्यादा एक्सटेंसिव फ्लैप रेज करने की जरूरत नहीं। इनको अगर ऑगमेंट करना है तो आई नीड टू रिफ्लेक्ट द फ्लैप। अगर मेरे को ऑगमेंटेशन इतना ज़्यादा करना है विच रिक्वायर्स नॉट ओनली हॉरिजॉन्टल, मैंने इम्प्लांट डाला, बक्कल एक्सपोजर नहीं है, कोरोनल एक्सपोजर भी है, तो ये तो हॉरिजॉन्टल हो गया, एक वर्टिकल ऑगमेंटेशन हो गया। जब मेरे को वर्टिकल ऑगमेंटेशन करना है तो I need to give vertical releasing incisions and augment the flap so that जो मैंने augmentation 2 mm का ऊपर किया फॉर एग्जाम्पल वो कवर हो पाए। मतलब we are talking about collagen membranes, PRF membranes, उसमें थोड़ा सा एक्सपोजर हो भी जाता है तो चलता है। जो नॉन रिजॉर्बेबल membranes हैं, strict no chances of infection are very high। Immediate में क्या है, so again same thing, so if I feel कि मेरे को स्टेबिलिटी मिल जाएगी या मैं गाइडेड कर रहा हूँ, एक्सट्रैक्ट विदाउट रेजिंग द फ्लैप, द रीजन बीइंग बक्कल प्लेट यूजुअली थिन होती है, सो एज आई टोल्ड यू वी रिफ्लेक्ट द फ्लैप, उसके रिजॉर्प्शन के चांसेस बहुत ज़्यादा, सो देन वी कैन गो फॉर फ्लैपलेस। बट अगर मेरे को लगता है कि बक्कल प्लेट फ्रैक्चर हो गई है या मेरे को लगता है कि बक्कल प्लेट है ही सीबीसीटी में दिख रहा है, तो देन आई हैव टू रिफ्लेक्ट द फ्लैप बिकॉज़ आई एम प्लानिंग फॉर अ जीडीए। What we have to keep in mind is the bone. जो मैंने पहला point दिया था, things to keep in mind. The first thing is bone. Okay. How much amount of bone I have, and then I have to decide flap कौन सा होगा, flap test कर सकते हैं कि नहीं, अगर augmentation required है तो कितना मेरे को augment करना है। तो for example horizontal augmentation करना है, तो many a times मतलब I avoid giving vertical releasing incisions। सीधा म्यूकोजिंजाइवल जंक्शन के बियॉन्ड के मैक्सिमम हम क्या करेंगे कि पेरियोस्टल रिलीजिंग इंसिजन दे देंगे, वो कवर हो जाएगा। पर अगर मेरे को वर्टिकल ऑगमेंटेशन भी करना है, मैंने इम्प्लांट के ऊपर भी बोन ग्राफ रखा है, तो मेरा जो सॉफ्ट टिश्यू था वो तो इस लेवल पे आ रहा था, मेरा इम्प्लांट ऊपर आ गया तो मेरे को इसे ऊपर लाना ही है, देन आई नीड टू गिव वर्टिकल रिलीजिंग इंसिजन एंड रादर टू वर्टिकल रिलीजिंग। दैट्स हाउ वी लर्न। सो इनिशियली जैसे मैम ने जो पहली चीज पूछी, व्हाई नॉट फ्लैपलेस, व्हेनेवर वी आर प्लानिंग फॉर जीबीआर फ्लैप उठाना ही पड़ेगा, एंड इनिशियल लर्निंग फ्लैप। So again, जैसे what we are doing, immediate कोई thesis नहीं कर रहे हैं ना किसी का immediate loading का, इसका thesis है, तो what we are following over here is not immediate loading, we are not following that until it's all on board। तो अब उसमें क्या है मैम, जैसे for example what we are doing, thesis में हम क्या करते हैं कि कवर जिंजाइवल फॉर्मर लगा रहे हैं, जिंजाइवल फॉर्मर लगा सकता हूँ, या मैंने जो आपको केस शो किया उन्होंने टेम्पराइज किया है, तो एक्चुअली देयर आर मेनी थिंग्स टू इट। सो इफ आई एम गोइंग फॉर फ्लैपलेस, आई नो गुड अमाउंट ऑफ बोन इज देयर, सॉफ्ट टिश्यू इज देयर, आई विल ट्राई टू गिव अ टेम्परेरी टू द पेशेंट, तभी मैं फ्लैप प्लस प्लान कर उसमें टेम्पराइज किया उसने, तो वो ऑटोमेटिकली क्लोज हो गया। नहीं, वो उसमें मैम हम फॉर्मर लगा के छोड़ देते हैं, जिंजाइवल फॉर्मर जो हम स्टेज 2 पे करेंगे उसी वक्त लगा दिया तो वो फॉर्मर बन गया। वो जो आपका कफ जो फॉर एग्जांपल हम 3 महीने बाद चाहते थे वो अभी बन गया। Now there are many things to it, tissue level implants and so that already come with this polished surface. उसमें क्या है आपका जो जिंजाइवल कफ है ऑलमोस्ट बन ही जाता है। So you have such implants also. So there are various modifications to it. हम अभी conventional थोड़ा सा ज़्यादा अब तो most often they are going for immediate loading. Immediate loading if you get दे देते हैं लोड हियरिंग एरिया, जैसे मोलर्स में अवॉइड करते हैं प्री मोलर्स तक तो आप दे रहे हैं। इंटीरियर में मैम इट डिपेंड्स, तो इफ यू हैव ऑगमेंटेड टू अगेन टेम्पराइजेशन कैन बी अ सेपरेट टॉपिक, so it can be implant supported, it can be like we can give a access line or a Maryland bridge, something like that for aesthetic, that can be a separate topic. तो अभी हमें so these flap designs are mainly for stage 1. Stage 1 मतलब हमने flap रिफ्लेक्ट किया और सिर्फ इम्प्लांट डाला, ठीक है। इसका जो stage 2 करते हैं हम उसमें एक्चुअली we can modify it. There are H shape, I shape design, you can apically position आपने देखा था, Palachi technique is there, so there are n number of techniques to play around with soft tissue to augment the soft tissue. Or we have to ultimately go for FTG or CTG. That is stage 2. So the simplest है because this is how you will start. And which we have now recently Navident is there, so जैसे हमारा GPS है सिस्टम, हमारे GPS देखते हैं वो गाड़ी चला रहे हैं, सेम वे यू हैव Navident, so वो गाइडेड सर्जरी से भी नेक्स्ट है। so basically drill will stop if you are not following the path, it will navigate. So sensors हैं robotic, जैसे robotic आर्म होती है वैसे, so your drill will stop if you are not following the pre-planned implant direction. वो सिस्टम ही वो है, नेविडेंट ही है। हमें अभी वो उसमें मांगा था हमने, तो वो 65 lakhs का है। Any other doubt? Any question you want to ask? So for interns, मैं कल बोल रहा था, any doubt here will remain for lifelong. If you are not asking us, you will not be able to ask anybody. अपने बैचमेट से पूछोगे, वो भी आपको वही बताएंगे जो उन्हें आता है। If you have any doubt, you should ask. Simplest of doubt. Crustal incision समझ नहीं आया, आप वो भी पूछ सकते हो। Clavicular समझ नहीं आया, वो भी पूछ सकते हो। हो सकता है आपकी वजह से 4 और लोगों का भला हो जाए जो नहीं पूछ रहे। बताया ना, mid crustal is the safest, provided I have good amount of keratinous tissue. बकरी अगर मेरे को ऑगमेंटेशन करना है या मेरे को ये लग रहा है कि आई कैन गिव अ टेम्परेरी विद मेरे को थोड़ा सा बक्कल टिश्यू ऑगमेंट करना है, तो मैं थोड़ा सा पैलेटल दे दूंगा। तो जो बेसिकली 2 mm टिश्यू अगर मैं मिड क्रस्टल देता, पैलेटल एरिया में पैलेटल फ्लैप में आना था, वो मेरे बक्कल फ्लैप में आना। तो उसका क्या एडवांटेज है कि जब मैंने ग्राफ्टिंग की, इम्प्लांट डाला और सूचर दिया, तो सूचर लाइन पैलेटली है, ग्राफ मेरा और इम्प्लांट जो है सेंटर में, तो इट इज अवे फ्रॉम सूचर लाइन। सो एनी सूचर लाइन जो हमने पढ़ा था, इट शुडंट गेट इन्फेक्टेड, लाइन थी ना, तो एनी सूचर लाइन इज द सोर्स ऑफ इन्फेक्शन। तो हमने अपना ग्राफ उससे दूर कर दिया, हमने उससे दूर कर दिया तो इन्फेक्शन के चांसेस कम। तो अगेन अब अगर मैं पैलेटल प्लेसमेंट कर रहा हूँ, तो मैंने जगह लिखा था फ्लैप के ऑब्जेक्टिव में ये था टू लोकेट द एनाटॉमिकल स्ट्रक्चर, जैसे मेंटल किया ऐसी चीजें भी कर सकते हैं। अगर मैं पैलेटल प्लेसमेंट कर रहा हूँ तो आई माइट रिफ्लेक्ट पैलेटली रिफ्लेक्ट करना वैसे ही अगर आप फुल थिकनेस कर रहे हो तो इट्स फाइन, वो रिसीड नहीं करता मुकोसा ना, आप उसे रिफ्लेक्ट करके देख सकते हो इंसिजन कैनाल कहाँ है। पर अगर मेरे पास सफिशिएंट अमाउंट ऑफ बोन है तो मिनिमल रिफ्लेक्शन इज रिक्वायर्ड। मिनिमल रिफ्लेक्शन एक्चुअली व्हेन वी आर प्लेसिंग इम्प्लांट क्यों चाहिए, क्योंकि व्हेन you are placing, I want you to see both buccal and lingual plates or buccal and parietal plates. Life becomes easier for you. दोनों चीजें नजर आ रही है ना आपके दिमाग में, ये 7 mm है, बीच में इम्प्लांट डालना है, बस एंगुलेशन करना है। आपने ये पैलेटल रिफ्लेक्ट नहीं किया तो आपको ये वॉल नजर नहीं आ रही, तो चांसेस ऑफ यू गोइंग buccally becomes more. What we are doing is we are guiding from here, guess कर रहे होते हैं ये सही जा रहा है, सही जा रहा है, away from any important landmark.